Case presentation. This is a 49-year-old man with cecal adenocarcinoma. He has history of uterine cancer in a sister and colonic cancer in his father, with history of colonic cancer in both before the 50s. In the surgical specimen, we found 22 regional lymph nodes, all negative for tumor, with no evidence of systemic metastasis identified. The first H&E slide is an image showing areas of well-differentiated adenocarcinoma with lymphocytic reaction at the edge of the tumor, with abundant lymphoid nodules resembling Crohn histology. Second H&E slide. This image shows an area of poorly differentiated adenocarcinoma with abundant lymphocytic reaction in the stroma and numerous intraepithelial lymphocytes. Then we have the MSI negative control. As you can see here, everything is negative, no nuclear staining in normal glandular epithelium, in lymphocytes, and in tumoral cells. Then MLH1 immunohistochemistry. Everything here is positive. Nuclear staining is detected in the nucleus of normal glandular epithelium, the nucleus of lymphocytes, and the nucleus of tumoral cells. This is clearly a normal pattern. To report something as positive, we need more than 50% nuclear expression with positive internal control. Next slide shows the PMS2. Everything is positive here. Nuclear staining is present in tumor and internal positive control in lymphocytes. Again, this is a normal pattern. Then MSH2. Nuclear stain is present in the internal positive control in normal glands, in lymphocytes, and tumoral cells are negative. This is an abnormal pattern showing that the MSH2 gene is silent. And this slide is the MSH6, same thing than previous slide. Nuclear staining is negative in the tumor and nuclear staining is positive in the internal control. Then we have the PCR. It was reported as 5 out of 5 macrosatellites unstable. So it's definitely a positive case for microsatellite instability reported as high. Final diagnosis. Microsatellite instability detected. Abnormal negative expression of MSH2 and MSH6 detected. The case is supported with MSI by PCR, showing 5 out of 5 unstable locus. And this is most probably a case of hereditary non-polyposid colon cancer or Lynch. However, final confirmation requires DNA sequencing in peripheral blood. What is MSI? MSI is a disorder or damage in the MMR genes that are genes involved in the repair of mistakes in the sequence of nucleotides in the DNA. 80% of MSI cases are sporadic cases not related with germline damage. 20% of cases are Lynch or hereditary non-polyposid colon cancer related with a damage in the germline. What are the genes affected in microsatellite instability? There are 4 genes studied. They are called the MMR genes or mismatch repair genes. They include the MLH1, MSH2, MSH6, and PMS2. MSI in sporadic cases of colon cancer. Sporadic cases are related to acquired methylation in the CPG islands of the promoter region of the MLH1 gene that makes this gene inactive and silent. The loss of the MLH1 gene is always related with loss of the PMS2 gene. MSI in the Lynch syndrome or hereditary non-polyposid colon cancer. Most cases in the syndrome are related to germinal defect in the MMR genes. The most common is the MSH2, always associated with loss of the MSH6. The damage of the gene is related with presence of repeated tandem sequences of adenine and cytosine that are replacing normal nucleotides in the DNA. Conventional cytogenetic studies and DNA amount in Lynch syndrome, they are completely normal in cases of Lynch or sporadic MSI. Defects are not detected by conventional cytogenetics or determination of haploidy. What is the importance of the screening studies in MSI? The screening is performed with immunohistochemistry or PCR for microsatellite instability. The screening tests are very important because they allow the identification of Lynch cases. The Lynch cases or hereditary non-polyposis colon cancer have a more favorable prognosis than other cancers, and the treatment with chemotherapy may be completely different. For example, they do not respond well to 5-fluorouracil. Requirements of the tissue for immunohistochemistry or PCR for the screening for microsatellite instability. You require 10% formalin tissue embedded in paraffin. The pathologist has to confirm that abundant tumor is present in the slide. The tumor is dissected and separated from non-neoplastic areas. 15 slides are prepared, and tumoral and non-tumoral tissue then studied in parallel. Lynch syndrome inheritance. First, it is an autosomic dominant syndrome. Penetrance is incomplete, so not all patients with the syndrome have a parent with cancer. The possibility of a parent transmitting the mutation is only 50%. Sometimes the syndrome appears de novo in a generation without a previous case in the family. The risk to develop cancer in a patient with Lynch syndrome in a lifetime is 80%, and most patients develop cancer in the 40s. Indication for MSI study, microsatellite instability study. First, colon cancer before 50 years old, then other carcinomas associated with hereditary non-polyposis colon cancer may happen, and they can be synchronicous or metachronicous, same thing that consecutive. They are stomach adenocarcinoma, small bowel adenoCA, transitional carcinoma, pancreatobiliary, endometrial adenocarcinoma, carcinomas of the ovary, glioblastoma, sebaceous adenoma, and keratoacanthoma. Histology suggestive of MSI high. Lymphocytic reaction is resembling Crohn's disease with lymphoid nodules in the tumor edge or more than 3 intraepithelial lymphocytes per high power field. Also mucinous tumors, signet ring type adenocarcinoma, medullary pattern with abundant lymphocytes surrounding a poorly differentiated tumor with solid trabecular or cribriform areas. Colon cancer or cancers related with Lynch syndrome in first grade member of the family, for example, parent, son, sibling, are all before the 50 years, and it's a very good clue that we have a case suggestive of MSI. Then we need exclusion of the familial adenomatosis polyposis, an entity with many adenomatous polyps, usually more than 100. However, I want to make a comment here. It is important to know that a solitary polyp in the right side of the colon may be the only tumor useful to study a member of the family with a possible Lynch, and sometimes we can find the abnormality of MSI in the polyp. Recommended algorithm for the diagnosis. First, I want to mention that if the history is highly suggestive and you don't have financial problems, it's probably better to combine immunohistochemistry and MSI by PCR. If you have financial problems, the following recommended algorithm is the ideal. First, you do immunohistochemistry for the 4-panel with MLH1, PMS2, MSH2, and MSH6. Second, if positive for MLH1 and PMS2, if it's abnormal for MLH1 and PMS2, most probably it's an acquired case due to hypermethylation. So you need to order our MLH1 promoter methylation test, a test that is performed by PCR, and also another PCR test that is the BRAF. If both the methylation test and the BRAF are positive, you confirm sporadic cancer and you rule out Lynch syndrome. If they are negative, you order DNA sequencing in peripheral blood, a test that is the gold standard for confirmation, but is very expensive, tedious, and complicated. Third possibility, you have an MSH2 and MSH6 abnormal case. Most probably is a Lynch case with a very high predictive positive value. You follow the DNA sequencing in peripheral blood. Then you have only PMS2 alone. Same thing. This case is most probably a Lynch case with a very high predictive value, and you follow the DNA sequencing. Fifth possibility, patient is only MSH6 alone. This is probably a case of Lynch, and you also do the DNA sequencing. And the sixth probability, immunohistochemistry is completely negative or normally, but the patient still is clinically very suspicious of Lynch syndrome. In this case, you order MSI by PCR. If all 5 locus studied by PCR are normal, it is probably not Lynch. If only 1 locus is unstable or abnormal, you call the result MSI low, and in this case you order DNA sequencing if the clinical presentation is suggestive. If you have 2 or more locus unstable or abnormal by PCR, you order the DNA sequencing. Thank you again for visiting my website, and please feel free to email me.